Thanks heaps for having me. So I just wanted to start, and I'm just hoping everyone can see the presentation. If there's any issues, we will send the presentation round. But I do have no real or perceived conflicts of interest in this space. I'm not funded by the pharmaceutical industry or the tobacco industry. I wanted to... I was going to say, yep. Start off by talking a little bit about Alfred Health and our journey to smoke-free, which hasn't always been smooth sailing. So just to give you a little bit of context about us as a health service, we're a big major metro health service, and in a lot of ways that makes us very, very lucky. We've got a lot of resources, but we're also got a really big workforce as an organisation. So when we look to implement something like smoke-free, there's a whole lot of education that comes with that across our 9,000 or so employees. We've got about 6,000 nursing staff. So again, when we look at work in this space, it is challenging for a large organisation to really ensure that all staff are across what we're doing. Here's a couple of images of Alfred Health. So this is our main courtyard within our health service, our main health service, the Alfred in Paran in Melbourne. So in the top left-hand corner, you can see a rather large designated smoking area, and that's basically how it looked about a decade ago in early 2008. And I'm really pleased that down the bottom there, we've got much better use of that space now. We've planted some trees, we've got seating and so forth. So I wanted to touch on our transition to smoke-free. So we went smoke-free back in May 2008, and this was prior to any legislation in Victoria saying health services should be smoke-free. And we had a CEO at the time who was all about doing things super quickly. She was actually nicknamed Nike because her philosophy was just get on and just do it. And so she gave us as a health service 3 weeks to go from being having designated smoking areas to being completely smoke-free. So within those 3 months, we were looking at, pulling down structures. We were looking at introducing new policy, introducing signage, and our objectives at this point were really quite narrow. We obviously wanted to reduce exposure to passive smoke for all people who access Alfred Health sites, and we wanted to demonstrate public leadership. But what happened to when we actually looked at evaluating the impact of this particular initiative, we had very mixed outcomes. We had a high awareness that things were happening. We were smoke-free, and that was because smoke-free areas were being teared down, signage was going up. But what still happened, which was an issue for us, was that we still had mixed compliance. So we had staff smoking on site, patients smoking on site, and at this point we were doing nothing to support our patients or our staff who smoked to either manage while being in a smoke-free health service or to quit smoking. So I suppose that in retrospect it wasn't that surprising that a few years later we actually had an involuntary mental health consumer who took Alfred Health to the Victorian Civil and Administrative Tribunal, and she cited an infringement of her human right to not be able to smoke while she was an involuntary mental health patient. This really shook Alfred Health's commitment to smoke-free. We did have a new CEO at the time, who was our current CEO, and we were able to convince him, that Victoria would be watching, and let's go through with this legal challenge and let's see what it said. And we really wanted to stand true to our commitment that health services should be totally smoke-free. So what basically was the outcome of this particular legal challenge, and there's been several others in Victoria as well as over in New Zealand, but there was no human right to smoke. Human rights will only extend as far as that they don't impact on other people, and when you think about the risks that come with secondhand smoke, smoking is not going to be one that's particularly protected. However, one of the outcomes of this particular case was that as a health service, being smoke-free, we could not force people into withdrawal and not clinically support them. So at this point, we weren't doing a whole lot of work around supporting our patients, particularly those involuntary patients, to manage their addiction and to minimise their withdrawal while they were with us. So So when it came to looking at a new approach the following year, we looked much broader with our objectives. So we still cared about reducing exposure to passive smoke. We still wanted to be seen as a public leader, especially in the area of, the leading cause of preventable death and disease in Australia. But we also wanted to facilitate smoking cessation among our patients and among our workforce. And we wanted to recognise that for a lot of our clients and patients that it may not be feasible to think about smoking cessation, but it might be around managing temporary abstinence while they're in a smoke-free health service. We also recognise the role of the health service in, collaborating with the other peak bodies in Victoria and ensuring that we keep on the trend to denormalise smoking. And for us, that was about reducing the risk of relapse for patients and also for staff who may have recently quit, knowing that one of the biggest drivers of people resuming smoking is the visual or smelling cigarette smoke. But it was also around preventing uptake. That sounds quite bizarre, but we actually had evidence to tell us that we had several cases where patients were coming into our mental health facility a non-smoker and leaving as a smoker. So as a health service, that was something that we certainly took seriously and we wanted to improve. So this time round, our actions were much broader than signage and policy. We recognised that comms was still really important, but we looked to different ways to communicate, including the use of social media, the internet and so forth. But we also wanted to ensure that we had a really robust process to what we called the clinical management of nicotine dependency. It's a bit long-winded and a bit wordy, but basically what we found was that for our clinicians, they considered smoking a public health issue. So we really wanted to use the terminology around this in a way that was clinical, that resonated with our clinicians, and that's why we kind of used that terminology. So we wanted to have a great process where people were being identified as smokers and being provided best practice support to either manage their temporary abstinence or to support smoking cessation. And that was underpinned by a clinical guideline, and we had very, very great engagement from all our heads and medical units within our entire health service. Obviously, we needed to do education as well. And when we looked at education around smoke-free, it was really important for us to put this on a parallel to education around hypertension, stroke management, CPR. So for us, it was about utilising the processes already in place for education. So for our nursing staff with a large nursing workforce, it was around online learning. For our medical staff, it was incorporating it within the yearly schedule for HMO and resident education, the utilisation of grand rounds and so forth. So again, just bringing it on par with everything else, normalising this as part of what we do as a health service. So when we came to look at what was the impact of this new approach, we thought it'd be good, but we were really pleasantly surprised with the results that we were getting. So we still had high awareness that we were smoke-free. We had increased compliance, so we had less people smoking on site, less people smoking around the perimeter, even though we weren't focusing on it as much. And we were achieving what we call best practice clinical management, and that's certainly something that all organisations strive for, whatever the clinical topic that you're talking about. So what got us across the line this second time? What was different and got us these great outcomes? Well, by no stretch, it was certainly our organisational leadership from our CEO, from our executive and from our board. And it was very much about us framing a little bit differently to how we typically would look around particular priorities. So it was very much seen as a problem that needed a solution. We wanted to communicate publicly and actively so that there'd be the expectation that if clients were coming to us, that if they weren't asked about their smoking and weren't provided support, that they would actually challenge that with the clinician looking after them. And it wasn't so much about why we should do this as an organisation, it was about how can we not. And our CEO is very much known for actually framing things like this and often sitting with his executive team and not getting them to agree with him about, why we should do it. He just challenges people in the room. Can anyone give me a good reason why we shouldn't be doing this? So it's reversing that traditional approach. And when we look at clinical leadership, again, this was a massive enabler for us as an organisation. We committed to best practice, we allocated resources, and we made sure we had that support for patients and support for our workforce. Again, aligning the education and having a real continuous improvement focus where we needed to measure performance, where we needed to innovate, test new approaches, and again, importantly, know that this is a long-term effort. It's not going to be something where we're going to tick a box within 3 months and smoke-free is going to be sorted. So with our clinical leadership, we really needed to define a lead discipline. So prior to, I suppose, this new approach in 2012, we actually spoke to our clinicians and asked them what they thought about dealing with smoking. And to my surprise, it was really quite prominent that everyone thought everyone else was doing it. No one disagreed that they shouldn't be doing it, but our medical staff thought nurses were having conversations with patients. The nurses thought the doctors were having conversations. The social workers thought, well, maybe they should do it. The physio thought, well, maybe they should do it. So there was no real process around it. So in effect, everyone's responsibility became no one's responsibility. So it just wasn't happening. We also needed to make sure that our approach to clinical leadership was integrated within existing practice. So while we were talking to the clients about something else, that we would also bring in smoking. It might be sometimes when the nurse was taking the blood pressure that they would have a chat to them about the relationship between smoking and cardiovascular disease. So it was important for us to ensure that these conversations were happening within existing practice, because we were never going to get a whole lot of cash from the organisation to do this particular piece of work. We wanted our approach to be systematic, every person, every time, especially in those areas with greatest challenges. So areas where we know that smoking prevalence is high. So for us, it was areas such as mental health, areas such as our HIV units, where we've got particularly high smoking prevalence. We also needed to measure our performance. We needed to normalise this. It was just part of what we do. Just like we measure and treat blood pressure, we ask about smoking, we provide advice and best practice support. It's just a part of our health professionals' role. And we wanted to use campaigns like Start the Conversation to emotionally compel our health professionals. So really use that consumer voice. And this particular campaign highlights it's unscripted, real patients where they've had really bad conversations with health professionals, and one of the clients in this particular video recalls a time where she saw a doctor. She brought up into the conversation that she was a smoker, and the doctor stormed out of the room on her. So it's I think really a campaign which encourages I suppose health professionals to see that these conversations are incredibly powerful, and when we don't do them or when we don't do them well, that can have repercussions on the patients. So our clinical approach actually sat with our pharmacists to lead, which is a little bit different to a lot of other models, certainly across Victoria. Now, it just made sense for us in our organisation as our pharmacists, our clinical pharmacists are part of our medical teams. So they round with all our doctors and we have a 7-day-a-week clinical service. And when you think about one of the best ways that you can support and manage withdrawal, it's with the use of medication. So for us, a pharmacy-led model makes sense. But it's also, it doesn't need to be that way, and certainly there's some fabulous models in Victoria where there's nurse and medical leadership in this particular area. So again, it's more around defining a discipline to take the lead so that it happens systematically rather than necessarily which discipline is best. This was supported by our pharmacists being able to prescribe nicotine replacement therapy, and that was supported by education in our clinical guidelines. Our nurses also being able to prescribe nicotine replacement therapy, again with the appropriate education, and this was all underpinned by what we call a treatment algorithm. So it's pretty much a process that was easy to follow, tested with our health professionals before we implemented around how they could do this as easily as possible. We also committed as an organisation to have all formulations of nicotine replacement therapy available and the costs associated with that. and we ensured that this was available on all of our ward impress through our health service. So there was no delay in access to these products for the patient. And when you think about people who smoke, that kind of makes sense. And I'm not sure if many of you know people who smoke or have talked to people who smoked before. And when you think about them smoking, they have a cigarette typically every hour or so. So if you think about their journey, they may be unwell by the time they call an ambulance, they get to hospital, they're seen by the doctors, they're prescribed NRT, they're waiting for it to come to the ward. There's going to be a significant delay, and that client and that patient is going to be experiencing withdrawal. So it was really important for us as an organisation to streamline that process as much as possible, therefore allowing our nurses and pharmacists to be able to initiate nicotine replacement therapy and to have that supplied there so that we can increase that timely access for our clients. We also recognise that as a health service that we see patients typically for quite a short period of time. Our average length of stay at our acute hospital is only about 5 or 6 days. So it was important for us to really appreciate what we needed to do at the point of discharge back to primary care and communicate appropriately with our primary care providers. So for us it was around actually having a standardised mandatory section within all our discharge communications back to our GPs. And having that information populate from our inpatient encounter. We're quite lucky with our electronic system that was able to be done quite seamlessly. We also recognise that as a health service there are patients we may know are coming to us before they arrive on the door of the emergency department, particularly patients who are having planned surgery. So what were our opportunities to really improve the number of people that are smoke-free on the day of surgery and stand to reap a whole lot of benefits as far as improved wound healing, decreased length of stay, improved analgesia post-operatively and so forth. We also introduced an outpatient service to really provide intensive face-to-face support for our most complex group, and also our Good News for Smokers campaign, which was our support program for our staff. So this is just a little video that will kind of summarise some of these initiatives and talk about the consumer voice as well.
Led by our pharmacists, Alfred Health provide patients with support before, during and after admission, helping patients who smoke to quit.
Quitting cigarettes is very hard and it's not good for your health and it's very expensive. The support from the Alfred was excellent. While I was trying to quit smoking, I didn't think I could do it on my own.
From this, we found our inpatients are 4 times more likely to quit than those who received no support. Our outpatient smoke-free clinic cessation rates are in the order of 42%, and over 95% of our patients who smoke are now identified and offered support to quit.
This has been a really important initiative for us. We're committed to helping patients who smoke to quit and ensuring those that do don't start again.
Kind of video highlighted, it was important for us to be able to show outcomes. One of the ways we were able to do this was the use of retrospective auditing, but we were able to demonstrate that the provision of advice and support increased from 14% to more than 95%, and we're really proud to say that we've maintained that performance for the last 4.5 years. And also that our inpatients were 4 times more likely to quit than those who received no support. So we were seeing quit rates of about 15 to 17% among those who were inpatients with us. Our Stop Before the initiative is certainly one of the things that I'm most proud of and really shows how integrating a conversation at a teachable moment within an existing interaction can be really powerful. So this was the incorporation of a brief intervention, a conversation about quitting smoking and the particular benefits to surgery that was introduced systematically within our pre-admission clinic. So for us, about 30% of patients having surgery will come through this particular clinic. And they tend to be those who stand to have the most, I suppose, complex admission. A lot of these patients will be diabetic or may have other chronic conditions that need management prior to surgery. So just this conversation about smoking, the provision of evidence-based medication and referral to support such as our outpatient clinic or our quit line resulted in more than 53% of patients who were smokers giving quitting a go before surgery. So 4 times the number of people were giving quitting a go prior to surgery after a conversation with a health professional. And when we looked at quit rates on the day of surgery, twice as many were likely to be smoke-free. So 7 or 8% of patients in our control group were smoke-free on the day of surgery, but after we introduced a systematic brief intervention, we saw quit rates of about 23%. These results are what we call biochemically verified, so we use an expired carbon monoxide monitor. It's just a way that we're able to make our research results more robust, so it's not just a self-report, and these results are also extremely statistically significant as well. So for us, this was a huge win to really capitalise on that teachable moment. And this will have significant benefits for an organisation as far as the cost to the organisation from extra length of stay, extra days in an intensive care unit, extra hours on a ventilator, more medication for wound infections and so forth. So the organisation stands to benefit financially from a project particularly like this. Our Good News for Smokers campaign was what we did to support our staff who smoke to quit. And we only did this a couple of years ago, and if I had my time again, I would have done this much earlier on. But we were able to get this across the line with our organisation, as we know that a smoking staff member costs an organisation roughly $3,500 US a year, and that comes from loss of productivity due to smoking breaks and from absenteeism. So for us as an organisation, we obviously cared about the health and wellbeing of our staff. But we also knew that staff who smoke was a cost to the organisation. So this campaign was, influenced by our staff who did smoke. So we actually got them together in a room and asked them what they wanted. So it was very much informed by our staff. And here's some of the experiences of our staff and also our team.
Alfred Health aims to create a workplace that promotes health and well-being, recognising the vital link between staff health and outstanding patient care. Tobacco smoking impacts our staff, our patients and us as employers, and is a leading preventable cause of death and disease in Australia. But the costs of smoking go beyond health. Our 2016 staff health check told us that approximately 4.5% of our 8,000 plus employees smoked. Through our Good News for Smokers initiative, staff had access to nicotine replacement therapy, face-to-face or phone consultations, group consultations, as well as emails and texts. And it worked. Up to 50% of the staff who joined became smoke-free.
Quitting smoking turned out to be a lot easier than I thought it would be, and I wish I had done it sooner. I feel great now, and I've felt supported by the staff members throughout the entire process.
And not only that, many of them have actually banded together for additional support throughout their quit journey, which is fantastic, and motivated other staff.
Okay, so I suppose just to touch on that, we know that social networks are really powerful in smoking, and we were able to reverse that with our support with our workforce to really have those social networks being influential in quitting. So as a big major metro health service on a busy main road in metropolitan Melbourne, particularly where there's always TV cameras out the front covering certain stories that are happening in Melbourne, perimeter-based smoking was a real problem for our organisation, and it was something that we felt affected the Alfred Health brand, and it was something that our executive and our board really cared about. So when it came to looking at how can we show that smoke-free and what we're doing clinically is making a difference, we came up with the idea of doing observational surveys. Pretty much just a fancy way of saying we walk around and count the number of people smoking. So we started doing that in 2012, early 2012, before we introduced our new approach. And we found at the moment that we started supporting our patients who smoke to quit, we had an 85% reduction in perimeter-based smoking. It's kind of gone up and down since then, but it's remained much lower than our baseline. So back in early 2012, we would have typically in an 8-hour period, 250, 300 patients, staff smoking just on commercial road. So for us, you know, you couldn't often walk along that footpath without being absolutely inundated with a whole lot of secondhand smoke. So at the moment that we started to clinically support our patients, we had that drop, and it's remained much lower ever since. So again, it just shows that approach to supporting people while being in a smoke-free environment to either quit or to manage their withdrawal has had some really great benefits for our image, but also for, you know, the community and exposure to secondhand smoke. So I suppose what's kind of got us to this point, what's been our continuous improvement philosophy and strategy? For us, it was having a really clear definition of success that needed to be beyond compliance. So it needed to be around looking at those markers around quit rates among our inpatients, among our staff and so forth. And I think importantly, an evidence of a problem does not mean that a policy is inappropriate or a failure. And we don't have, you know, that mentality that we must have, you know, 100% of staff vaccinated for flu. We'd love it, but we don't get it. But it doesn't mean we say, oh, well, we're not going to bother vaccinating people anymore. Same with hand hygiene. Don't know how you guys go over here, but it's not often that we get 100% compliance with hand hygiene. But again, we don't go, oh well, it's a problem, we're not going to do it anymore. So I think the framing of what success looks like in this space is really important. Consistency is also incredibly important, and thinking of a patient and their journey through a health service, they'll often transition through various clinical areas and wards. They might go from the emergency department to an intensive care unit, and then to, you know, to a general ward before being discharged. And you can appreciate that if there's an inconsistent message about smoking, and inconsistent support around managing that temporary abstinence or supporting long-term cessation, that may be a cause of agitation or aggression for that particular patient. So we know that consistency is incredibly important, particularly in smoke-free. I think it's also important to really appreciate that we know that there are massive inequalities in smoking. We know that there's populations, particularly mental health consumers, particularly Aboriginal and Torres Strait Islander groups, where they experience more of the health burden and the financial burden of smoking. So the last thing that we wanted to do as an organisation was to have inequalities in quitting. So we wanted to ensure that the provision of support was provided to everyone regardless of their reason for admission, and we didn't have any exemption within our mental health services. Clinical leadership was also really important for us. It couldn't just be an OH&S issue, and when it came to looking at how do we influence clinical practice, of course, evidence and the literature and research is important, but for us it was also using plenty of emotion. It was using that patient voice of why you know, you're not talking to me about smoking. And I can recall an example from many, many years ago in a general ward, 4-bedded unit within our main general medicine ward. 3 of the 4 patients smoked. There was a 70-year-old lady who was admitted for COPD. She was spoken to about her smoking. We had a 40-year-old patient who'd had an acute cardiovascular event. They also felt it important to talk to him about smoking. But there was a 30-year-old patient who'd been admitted after an overdose, homeless, mental illness. And everyone thought, oh, well, it's too hard for him. He's got enough going on. And he actually heard these other conversations happening and called the staff on it and said to them, what makes it okay for you to decide, you know, what should happen? I want support to quit. I can't afford it. I can't access healthcare. It's something that's on my radar. So I think it really brings up that idea that we should be offering support to everyone regardless of what we perceive to be the best thing for them. I did want to touch on smoking and clinical aggression because this is incredibly topical in Victoria, especially after the unfortunate incident where one of our cardiothoracic surgeons was assaulted and unfortunately passed away. So there still is this perception among health services that being smoke-free will increase agitation, aggression and occupational violence. In actual fact, the opposite is true when it comes to the body of literature. And it actually shows that when you do introduce a comprehensive policy, so something that's beyond policy, signage and comms, you're doing something to support your patients to manage their withdrawal and support cessation, there tends to be no increase in aggression or violence. And there's a whole lot of literature around that. Myself and Sarah White from Quit Victoria have actually done a bit of a lit review on that, and I'm happy to share that if you think that that's helpful for your organisations. We know also from the literature that acute nicotine withdrawal has been shown to increase aggressive behaviour. And when you look at what happens to someone when they're in nicotine withdrawal, the symptoms are things like irritability, agitation, anxiety, changes in mood. And so it makes sense that if we don't manage withdrawal, that patients are going to be uncomfortable and may exhibit some of these signs. And I challenge health services and organisations to think about how we have well-developed processes in place for clinically managing alcohol withdrawal, for clinically managing drug withdrawal. But when it comes to smoking, we don't tend to have that same lens. But the data is really, really strong to show that if we don't do it well, there is an increase in aggression among our patients. And as health services where we care about patient outcomes and staff safety, this is something that's really real and where we can really have an impact. Alfred Health is also in the middle of doing a little bit of research in this space. So we bit off a little bit more than we could chew. We came up with this amazing idea that we would retrospectively audit every episode of clinical aggression within a year. So for us, just at one campus, it was about 1,300 episodes. So it's taken forever, but we're getting there. And I'm super pleased that we've finished the data collection and we've done some interim analysis with some of the data from the Alfred. But I think this is quite interesting and probably no surprise to you guys, is that when we look at episodes of clinical aggression and what we call code grade, the number of patients involved in a code grade and smoking prevalence is 51%. And when we look at smoking prevalence among all our patients at the Alfred, it's sitting kind of 17–18%. So smokers are grossly overrepresented in episodes of clinical aggression. We then took a little bit more of a deep dive and tried to understand our most highly dependent smokers, those that stand to be at the higher risk of withdrawal. And for us, there was 81 patients involved in an episode of clinical aggression, and they were responsible for 180 episodes. So patients were having more than one episode. So it raises the question, what could we be doing to prevent these from happening? So we tried to understand what the relationship with smoking was, and I was pleased in that we found in the majority of cases, 94% of cases, that patients were being asked if they smoked, they were being assessed, and they were being provided or prescribed clinically appropriate nicotine replacement therapy. But when we came to work out were they using it, only half of them were. And when we looked at were these patients in withdrawal, the majority of them were, 81%. So for us as an organisation, we've looked at this data and we're trying to understand, okay, well, we're prescribing it and the patient's not getting it, what's going wrong there? Does there need to be some more education with our consumers, with our patients, with our workforce around the idea that NRT is great for cessation, but it's also incredibly helpful in minimising withdrawal and making patients more comfortable while they're in a smoke-free health service. So we're also in the middle of, with this data, looking at doing some logistic regression to really be able to show that nicotine withdrawal is an independent predictor for code grade. And I think if we get that data, this is incredibly powerful for organisations because we obviously all care about patient outcomes and staff safety. So what does this all mean for supporting patients who smoke? Well, realistically, a lot of patients may choose to what we call abstain temporarily, resume smoking when they go home. Some will take that opportunity to quit completely. But I think it's really important that we need to, as health services, offer support immediately on admission because they're going to be in withdrawal if we don't. And that conversation might initially be about coping, especially while they may be stressed and overwhelmed, and lead to a conversation around cessation down the track. For For many patients, it is inevitable that they will experience some period of abstinence. And it might be because they're hooked up to telemetry, it might be that they're fasting for theatre, it might be because they're waiting to go to a scan. So we need to have a robust process, and it really is a clinical issue that we should be managing withdrawal. It's not something that certainly, in my opinion, is something that we should be able to opt in and out of. We're a health service, we've got a patient who is dependent, they will withdraw unless we support them, so we should just go on and get on with doing it. I put a bit in red there for those of you who can see the presentation, and if you take, I suppose, nothing else away from today, I think it's really important that we really recognise that it is not okay to force patients into withdrawal. We wouldn't force them into alcohol withdrawal, we wouldn't not manage their drug withdrawal. And when it comes to nicotine withdrawal, the symptoms are predictable, they're preventable, and they're treatable. So for us as organisations, it's a really pivotal opportunity for us to do it well, and minimise, the discomfort that patients may experience. So now I just wanted to touch a little bit on why it's so hard to quit, what best practice looks like, and a little bit about medication. So I think it's important that we always remind ourselves that people who smoke aren't weak, nor are they just making a bad lifestyle choice. Why they smoke is complex. They're dependent, they have an addiction, but they also have a whole lot of behaviours as well as psychological connections that are built up over generally decades of smoking. So it's important for us to remind ourselves that and to really understand that these patients, these clients need to be supported. Nicotine dependence really needs to be seen as a chronic medical condition. So it's a bee in my bonnet when I see certainly some health services in Victoria, put smoking under the social history or under the lifestyle section. It is part of the medical history, and we need to assess and we need to treat and support. Assessment is really important for us as an organisation. The way we wanted to do that needed to be as streamlined, as simple as possible. So we use what we call the abbreviated FAGASTROM, or the Heaviness of Smoking Index, which is at the bottom of the slide there. Easy, couple of questions. How soon after you wake do you have your first smoke of the day? And how many cigarettes a day do you smoke? And it kind of gives you an idea of how dependent they are. The more dependent, the more medication and the more behavioural support that they will generally need. I also wanted to touch on, I suppose, one of the biggest misconceptions that certainly sit with consumers who smoke, but also does sit with health professionals. So for a moment, I just wanted to kind of go through what happens when someone smokes. So when someone has a drag on a cigarette, within about within about 30 seconds, nicotine binds to what we call the acetylcholine receptors in the ventral tegmental area of the brain. Because that process happens so rapidly, the body responds by releasing dopamine, so one of the feel-good chemicals. So for the person who smokes, they perceive that they have a cigarette, they get some dopamine release, it's positive reinforcement, so they want to keep that behaviour going. So they perceive they smoke, I have an improvement in mood, improvement in my levels of anxiety, concentration, and so forth. But for a moment, let's just think about nicotine doesn't hang around in the body for very long. It's got what we call a short half-life, so it can no longer hang around on those receptors, so you no longer have the dopamine. So dopamine levels start dropping. The person goes into withdrawal, they start to feel pretty crap, and so what do? They want to pick up a cigarette to continue that process. So when clients say to me, I smoke and it helps me manage my dependency, in actual fact, it's really just reversing those withdrawal symptoms. And again, when we think about when people go into withdrawal, the symptoms are pretty awful. Dizziness, changes in mood, changes in concentration, irritability. And they also peak about day 1 to 2. So again, when I hear clinicians and I hear health services say, oh, we'll wait until they're a bit better before we start talking about smoking, they've been through the worst of the withdrawal generally by the time that gets done. So a systematic, early process is what's best in this space. I also don't want to, I suppose, underestimate how significant these psychological and behavioural connections of smoking are, and this is really where behavioural support comes in, and behavioural intervention provided by services like Quitline, and I believe that there's a few face-to-face services in WA as well where patients can access face-to-face behavioural intervention. So what can we do as health professionals? We've got to remember that what we say does resonate with patients. And brief advice does prompt people to quit. It's what we call a number needed to treat of about 1 in 33. So for every 33 conversations we have with someone about smoking, one of them will go on to quit. So if you think this only takes you a couple of minutes, for an hour or two of your time, one of those patients is going to end up smoke-free. So number needed to treat for things like aspirin for cardiovascular prevention are about 1,667. So the number needed to treat in this case is so much better, yet we just don't do it as much. So what we say makes a difference, and we've got to remind ourselves that. Also replicated by some research in the UK, our health professional advice still is the greatest trigger. And there's also some new data around stage of change, and it's not often as clinicians that we get told to skip a step, but we actually know now that we don't need to assess stage of change. And this is some data from over in Scandinavia where they asked people whether or not they wanted to quit smoking. 11% said, yep, I want to quit, and 89% said, I'm not interested. But they actually just went on and gave treatment to both. And surprisingly, a quarter, 24% of those who said, I'm not interested, took up the offer. And when you look at the short-term quit rate, 37% of those who weren't interested were smoke-free. So let's just get on and give support to everyone regardless. And I'm not sure about you, but, certainly when I think about, improving the amount of exercise I do, my willingness to change changes multiple times during the day. I wake up in the morning and think, yes, I can do it, and then I see it's raining and think, no, I don't want to. So again, let's just get on and give support to everyone regardless of their perception of stage of change. And it really is the offer of support that's so important. Some data again from the UK in GP settings, but I think that the principle here should resonate with us all. If as a health professional we talk to someone about, see a patient but don't talk to them about smoking but know that they smoke, they are going to be statistically less likely to quit than if we hadn't even seen them at all. And you ask these patients why, and they say, well, my health professional knew I smoked. They didn't say I should stop. It mustn't be an issue. They rationalise the behaviour. Then if you say, hey, you really should quit smoking, but you don't offer any support, only a small effect. And again, you ask people why. Well, I know I shouldn't smoke, I just have no idea how to quit. So when you offer help, and it might be you providing the help, it might be you referring them to someone to provide the help, that's when you get the biggest change. And the number of people having quit is significantly higher. So when you're having these conversations, you can say things, do you want help? Doesn't sound overly appealing to me. So when I'm doing it, I make sure that the offer of help and support is emotionally salient. I'll say things like, the Quitline has a brilliant stop smoking program, it's free and we can get you signed up today. One of my other patients, like you, really struggled, but do you know what? I did A, B and C and they've quit. I can line this up for you now. So we've got to make that offer of support, really quite emotionally salient and compelling. So I'm just going to finish with a couple of slides around what best practice looks like. There will be a few that we're not going to get through in the interest of time, but the whole presentation will be made available. But certainly what we know is best practice, gold standard, is the combination of medicine and behavioural support. So as health professionals, why should we use anything but? So there's medicines available. The most common is nicotine replacement therapy. The best way I describe this to patients and to health professionals is it's a little bit like cold and flu tablets. It takes away the symptoms a little bit and makes it easier for you to get off on your day. So it's not a medicine who is going to reduce the urge to smoke completely, but it's just going to make them a little bit more comfortable. It's efficacious, it's safe. But the key points with this is that we need to use it for long enough, for a minimum of 8 weeks, and we need to make sure that that client and that patient also has behavioural support. Just a little bit of a pharmacokinetic graph, because I am a pharmacist and a little bit of a nerd at heart. But I think this describes quite nicely what to expect from any of the nicotine replacement therapy products. So you can see the pink line, which is the cigarette. You get quite high levels of nicotine quite quickly after having your cigarette. None of the other products, the spray, the gum, the lozenge, the inhaler, deliver nicotine anywhere near A, as quickly, or B, in as high a level. So if your client thinks that their nicotine replacement therapy product is going to work like a cigarette, they're going to be bitterly disappointed. So it's important that you as clinicians and also as patients, we make sure that they understand what to expect from these products. Otherwise, they are going to think that they don't work. I'm going to finish on this slide here before just quickly doing a summary. But what we know now is that combination therapy, the use of two different nicotine replacement therapy products together, is gold standard. And I was really pleased that from the operational meeting this morning, there was one health service that's already doing this, which is amazing. So it's the idea that you use a nicotine patch to provide steady protection to control what we call baseline cravings. So I say to people, think of it a little bit like your preventer for your asthma or your preventer for your COPD or your long-acting opiate, your OxyContin. And then you have one of these other products, the spray or the lozenges of the gum, that acts more like your reliever. So it gives you that quicker and more flexible relief. We know that this is more efficacious, and we also know that when it comes to adverse effects, they're no higher than if patients just use monotherapy. And if we go back to this, we know that one product alone is not meeting the nicotine requirements. So it's quite often you'll hear patients say, I'm using the nicotine patch, I'm not smoking as much, but I'm still smoking. And it's because we're not giving them enough of the replacement therapy. So there's a couple of slides on Champix, which is something that I think that it's worth considering, particularly in the outpatient setting, as a medicine to support cessation. But I just wanted to, I suppose, conclude with people who smoke are expecting you to have a conversation with them about smoking. Know how to offer support, know what support's available within your organisations, address any concerns that people raise. Having this conversation doesn't take long and can make a real difference, and best practice is obviously the use of medicine plus behavioural support together. My email address is there. I'm more than happy to provide, any of the journal articles or any more advice or resources if you feel it's helpful within your organisation. So feel free to contact me at any time at e.dean, or there's a whole team of us in the prevention department at Alfred Health if you have a more general query. That's it.
Thanks, Emma, for your very inspired presentation. We really appreciate that. We've got a couple of moments left that we thought we'd offer an opportunity for questions. So I'm wondering if you have a question, could you raise your hand? We've probably got time for two or three. Bunbury Hospital?
Yes, Emma, could you please just give us a bit of an outline of how the outpatient clinics might work?
Yeah, so the outpatient service for us was all around targeting the high priority population, which we felt just wasn't going to be suitable for services like telephone counselling. We just felt that for a lot of our high priority population, they wanted face-to-face support, and we needed to provide funded nicotine replacement therapy. So for us, it was a service, or it is a service that has eligibility criteria, so we don't take everyone who gets referred. We do make sure that everyone that we don't take gets referred proactively to other services in the area. So there was a cost to the organisation in this space, but basically we started up the program with a little bit of a grant, measured our outcomes, and then put forward a business case to the organisation, and it's been operationalised ever since. So I think that's sometimes what we need to do if we don't always have, access to, a pot of money to be able to do what we'd like. Look at opportunities to either have grants, look at opportunities for various components of the organisation to contribute a little bit of money, put something together, measure the performance, and then pop that business case together. So we've got some information on our website around our clinic, so we can incorporate the link to that as part of the presentation as well.
Thank you. Were there any other questions? Nicotine?
You've demonstrated in your presentation that you've been able to work up from very little to methodologically knowing a lot and justified yourself within that, and you're to be praised for that. But you've not said anything about actually treating the root cause and stating the blindingly obvious, about actually tackling government and saying just quadruple the price of these things, tax them off the market, and all the job will be done for us. You're actually just making work for yourself, and good for you in making your job for yourself, because you'll never be out of it. But you're actually not dealing with the root cause at all. We live in a country which is part of the Pacific group of nations. The large tobacco companies are spending thousands upon thousands of dollars per day going out and getting new people to smoke weekly and day upon day, and then those people are coming into this country and coming to New Zealand, where I'm from, and they are bringing their healthcare problems with them. All you've asked us to do is stick our fingers in the dike and say, oh, look at this, aren't I doing a good job? I'm stopping things happening, without actually addressing the root cause in any way, shape or form.
Yeah, look, I would agree and disagree with you. I think just taxation of cigarettes, unless we're investing that taxation back into support programs, it actually becomes regressive, and it's really hitting those high priority populations. I have patients who are spending the entire of their disability pension on tobacco, foregoing shelter, foregoing food, and certainly taxation is an important component of it, as is smoke-free legislation, as is plain packaging, mass media, but we do need to recognise that this is incredibly addictive, and these other measures all have a part to play, but for particularly those high priority populations that are incredibly dependent, supporting cessation is what we need to do. So I think, certainly there's lots of components of tobacco control. As a clinician, the majority of my work is in the clinical space, and it's important that we have these other components, but we do need to recognise the significant addiction underpinning why people continue to smoke and provide support.
Thanks, Emma. I think we've got time for just one more short question. Nothing more. I can't see anything from the VC. Any questions from the room? No? Well, I'd like to thank Emma very much for her presentation. I think the clear message for me is, how can we not? And I think it's really interesting to know the figure that we need to have 33 conversations to enable one person to quit. And I think that as clinicians, that's a really significant figure for us to take on board and to not be discouraged when we feel that our efforts are not having an impact. And also, you've clearly shown that your strategic approach has worked, specifically with 85% reduction in perimeter smoking, which we all know. In our WACHS facilities, we probably all experience that as well. So thank you so much for your time today. Carol, was there anything else that you wanted to add?
No, I agree with you, Kate. The take-home message for me is also, how can we not do this? And I think there's a great strength in, what you've demonstrated in providing support and comfort for patients who are experiencing withdrawal. The clinical engagement and the role of clinical engagement and leadership at all levels, I think, is something that we need to work harder at in WACHS, and to embed it into existing practice, because it can't be one person's job. No one profession has the time to devote to smoking cessation, but we all have a part to play. Thank you.
Thanks, Kate.
Yeah.
Well, thanks everyone, and thanks for your time today.
Thank you.
Thank you. Thank you.